Welcome everyone to today's webinar, AR Management in the Age of COVID-19, Strategies and Techniques for Overcoming Denials. I'm Morgan Hafner with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. We will also have a series of audience polling questions during today's webinar. When we reach each poll slide, the poll question will pop up automatically on your screen. We will give you a few seconds to answer from the options on your screen, and then you can click submit. Thank you in advance for your participation. Today's session is being recorded and will be available after the event. So you can use the same link that you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenters. First is Jonathan Wick, the Principal of Healthcare Strategy at TransUnion Healthcare. His 25 years of healthcare experience in acute care, health IT, and insurance settings gives him a vast knowledge of and keen insight into the inner workings of the revenue cycle across the continuum of care. John is an active advocate of legislative changes that evolve the healthcare industry. He's the author of Healthcare Revolution, The Patient is the New Payer, and his latest book is Healthcare Evolution, Helping Providers Get Paid in an Era of Uncertainty. John frequently speaks as a thought leader at state and national events, as well as conferences. I'd also like to introduce Ryan Bain. With over 19 years of experience in the healthcare industry, Ryan is currently the Corporate Vice President of Systems and Analytics for Prospect. Prior to moving to Prospect, he worked extensively with for-profit and non-profit healthcare organizations, including hospitals, clinics, and academic medical centers, to identify and implement strategic and operational improvements. Ryan's current focus is on creating advanced clinical and revenue cycle analytics that help Prospect hospitals gain a deeper understanding of their business and provide insights on where leaders must concentrate their time. And finally, I'd like to introduce Cassandra Mitchell. Cass is the National Vice President of Strategic Revenue Optimization at Prospect Medical Holdings. She works with hospitals on both the East and West Coast, focusing on risk aversion, utilization management, and revenue recovery. Prior to joining PMH, Cass worked for 15 years at Yukon Health as the Chief Revenue Cycle Officer and initiated her career as an auditor with Anthem Blue Cross and Blue Shield. She is a past Board of Directors member for HFMA and is a recipient of their Gold Merit and Distinguished Service Awards. At this time, I'm pleased to turn the floor over to John to begin today's presentation.
Thank you, Morgan, and thank you everyone for taking time out of your busy day to learn about accounts receivable management and what my panelists and I will talk through in terms of maximizing that at your organization. Roadmap for today will be these four areas. I'll kick it off with some market trends here in 6 or 8 slides, just talking about impact of COVID to hospitals, share some TransUnion data, and also just some insurance projections that we think are going to happen to further disrupt the market. And then I'll turn it over to Ryan, and he'll go through some case studies with his organization, and then Cass will tell us how to fix it all through some root cause analysis and some other things, and then we'll open it up for Q&A with about a quarter till as we come through. So we had this chain of events happen with COVID. There's a lot going on with this slide, and we've all traveled it back since March. It's been a very odd year, I think, for most of us, and it certainly has disrupted cash flow at all healthcare organizations to a very large extent. We had an elective procedure suspension by our Surgeon General, shelter-in-place orders that resulted in less commerce, unemployment, under and uninsured. We had some government regulation and relief, but that yellow sphere there really has created this administrative burden to the providers from a documentation and basically workflow standpoint. I would argue that the dust has settled for most, but we're still kind of like a dog coming out of a lake shaking her tail and really wiggling out everything that's happened, and we're trying to get back to some level of normalcy with our cash flow and also retrospectively looking at, what happened? Did I get paid right? Where are my dollars stuck? And how do I better insulate myself going forward? And I think we're going to have more headwinds into 2021 from an insurance disruption standpoint and a payment standpoint with some of the outcomes of COVID, and we'll talk through those in a minute. And it's going to be important as you listen to Cass, Ryan, and I today to think about how am I going to capture every last penny in my revenue cycle, and am I positioned well to do so with my people, process, and technology as we move forward? Because sustainability and margin impacts are going to be a very, very important and probably strategic priority for many organizations that are on the phone and those that you'll interact with. This is some data from TransUnion surrounding hospital visits since the beginning of the year, and pronounced obviously as that deep trough there in April surrounding the deferral of elective procedures and basically a halt of most of the operations from an ambulatory standpoint at hospitals, and we saw that trough out at about 63% on the outpatient side, 30% for inpatient, and 52% for the emergency department. That's recovered since. We just released a press release yesterday that talked through some of this. We've had some others that we've been following, and really we've seen outpatient come back to some level of normalcy. It's following that 0% line, or what were your pre-COVID levels. It's right there. Inpatient has lagged at -8%, as you can see, and what's really interesting to me is ER is still down 25 points. I don't know that ER is going to come all the way back. I presented on a conference yesterday to EDMPA, and I was talking to a lot of emergency physicians, and they're very reflective of this, and they're doing everything at the organizational level to get that volume back. Something that's important to think about is most hospitals don't make a lot of money in an emergency department. It's actually a loss leader. However, it is a feeder for all of the other things like inpatient, surgery, imaging, lab, cardiology, and those things. And not having that referral base can have detrimental financial impacts as you go down the road. So much so that you've seen this strain happen. Beckers, who's hosted this webinar, had an excellent article and are still tracking this, and have said that as a result of these elective procedures being suspended, several systems have expected to lose or will lose a very large chunk of their annual revenue. 266 hospitals furloughed employees. 38 hospitals furloughed are actually laid off workers. Chris Kearns, a buddy of mine from the advisory board, has actually mentioned that 51% decline in revenues are expected from this pandemic, and that takes a long time for a hospital to bring back those numbers. The other thing is a lot of these people that maybe were put on pause may or may not come back. Those of you that have worked in hospitals or are working in hospitals know that retention and recruitment are a very difficult issue. So as you're looking to impact your revenue cycle, outsourcing and other options, which Ryan and Cass will talk about, are something certainly to consider as you're getting your cash flow back up to speed. So insurance disruption is likely from COVID given the unemployment rates. There's a lot of numbers on the page here. This is a study from Oliver Wyman. But basically what you see are three scenarios in those bars: 2020 baseline unemployment, 15, 20, and 30% respective unemployment in the blue, turquoise, and gold there in scenarios. Basically we anticipate in the large group market a significant shift in employer-sponsored insurance, dropping from about 97 million members down to 74 million members at the worst case of 30% unemployment. That has to be made up across these other markets. Either they get nothing, they stay without insurance, they go to an individual exchange plan, the ACA plans, they get picked up in Medicaid, which we have seen. Medicaid's up about 10% from that of last year, and then Medicare, where unemployment ended up, as of at least the beginning of this month, was 8%. So it was on the low end of this. That said, you're still seeing 6 to 7 to 8 million folks that had funding mechanisms in place that no longer do so. That will result in patients coming into the market or switching to different types of insurances, which can disrupt, and as Cass and Ryan will talk through, certainly impact how your cash is flowing and barriers that may present concerning changes in insurance. TransUnion put together a brief in April surrounding possible scenarios that would possibly happen during the COVID-19 pandemic, specifically as they relate to revenue cycle in hospitals. The link to this brief is down here in the lower right corner if it's something that folks want more detail on, and there's lots of other commentaries and things. But it's important to understand that these 8 things did happen and will continue to happen, especially as many regions in the United States, as Beckers has reported, are experiencing a third surge, and their EDs are starting to pick up. I've heard talk of suspension of elective procedures in certain markets as well if things like PPE, staffing, and patient safety come to mind. Unemployment, as I just mentioned, will happen. Capacity supply chain concerns will always be there. Bad debt, staffing constraints, hospital financial position, insurance disruption, and certainly high-risk patients that may or may not have been picked up by virtual visits are all scenarios that'll happen. And impacts and recommendations are listed here. Cass and Ryan are going to have a lot for you. Specifically, it relates to your claim inventory, but please reach out if there are things that you need and want to understand better as things impact your organization that may or may not be out of your control. Big numbers here. 58% of commercial claims denied. These are all pre-COVID. $257 billion in reductions in payments for the next 10 years. Uncompensated care has upticked to $41.3 billion. That came up from $38.4 billion in 2017. It's an AHA report. I anticipate this number to hit the $45 billion mark for the 2019 and 2020. It easily probably get into the low 50s depending on how well we recover from COVID. The last number there is a COVID number. That comes from the AHA. The AHA projects for hospitals they are going to lose $323 billion due to the deferral primarily of their elective procedures. There's some indirect COVID costs and supply and labor costs there as well, but the lion's share of that $323 billion is frankly top-line revenue that may or may not be recovered based off those graphs I showed you earlier. You have to have a roadmap to profitability. Cass and Ryan are going to go through that with you in their experience that they've had at Prospect Medical Holdings. These are some key tenets I put together for you. You got to get to normalcy with clinical operations. I think most of you are there. Proactive patient engagement. I've seen many campaigns both in my own market and in others about saying how safe your organizations are and how you need to get that volume back. And if you're sick, come to the hospital. And if you need elective surgery, come to the hospital. You're going to have to be very disciplined in your cost control from a labor, supply, and project standpoint. High yield initiatives, similar to those that TransUnion Healthcare has, are also very, very important to look at. Where are things that I could do to turnkey right now to drive cash to my organization, to get yield, to improve my margin, to insulate myself from further disruption? What are those things and how can I operationalize them going forward? A continued effort to drive costs and reduce those costs will happen, and we are in a new normal. I hate that term, but we're there. Work from home, virtual health, subpar ED utilization, and other things are all new things. That all results in what I circled there at the top in payment integrity. Are you maximizing your payments from payer and patient? And how are you doing that? And are you leveraging people, process, and technology to do so? I wanted to applaud all of you on the phone. It's important. This was unprecedented times that we went through in the last 6 months. This is a picture of a hospital applauding a COVID patient that was discharged, but it has been a really interesting Q2 and Q3, and we're in the home stretch to Q4. I think we're going to come out of this better than we have as an industry, but we're going to have to really stick to the knitting and the blocking and tackling of revenue cycle to continue to do well, because I think it's going to get harder, not better, to capture dollars, given all the disruptions that I talked about. I'm going to turn the con over here to Ryan. He's going to walk you through what Prospect Medical Holdings has done. Ryan.
Thanks, Jonathan. As a quick overview of Prospect, we are a multi-state health system that operates 17 hospitals with nearly 4,000 beds and over 160 clinics. We currently have hospitals in 5 states and expanded most recently at the end of 2016 into the Pennsylvania and Connecticut markets. Due to the growth through acquisitions, we very quickly became an organization with operations in 5 states and several business offices and many systems to reconcile. So we had the typical challenges of multiple patient accounting systems, and as you can see from the diagram, we have Cerner, actually a couple versions of Meditech, Paragon, and others, multiple billing software providers, challenges around managing AR with no consistent workflow tool, no standard way of analyzing or valuing accounts receivable, and no standard analytics definitions or metrics. And due to these known challenges and complexities of managing the AR, we engaged the help of software partners to provide capabilities for several things, to provide consistent views of AR, intelligent workflow, contract management, denial and underpayment capture, and other analytic capabilities. We also built out a systems and analytics team to be the hub for revenue cycle systems with a goal to build out consolidated data and system functionality, and then to maximize the use of rev cycle systems and new software to produce consistent workflow and meaningful analytics across the organization. We recognized in prior periods of rapid change that we needed to have a coherent strategy to manage our accounts receivable, and many lessons and focus areas are relevant still today. So I'll talk about the 5 key areas of focus to drive performance, and then we'll get to how this helped us navigate more effectively during 2020 and the current pandemic. First, I'll stop for a moment for the first polling question.
Absolutely. Thank you, Ryan. So our first polling question for you all is, where are your biggest challenges with AR recoveries and denials? Is it inpatient, outpatient, behavioral health, telehealth, or other? We'll give everyone about 10 seconds to answer that question. Okay, excellent. So let's take a look at the results. So majority are seeing the biggest challenges in inpatient, closely followed by outpatient, and then, telehealth and other following up. So Ryan, I'll pass the floor back to you.
Thanks, Morgan. So our first focus area for driving performance, if you see the slide that is up now, was comprehensive and accurate denial capture. So we focus on using standard tools across the organization to pull in all denial information and focus on true denials with revenue at risk. So some of our legacy systems didn't have good capture of denials, or they included too many false positives with line item denials on paid claims. So we focused on the ability to capture all denial inflows as well as recoveries and outstanding inventories for a broader view of all potential revenue leakage. And ultimately, the key to us is tracking how much of our expected reimbursement is collected, and then see where the largest gaps are coming from. Is it specific payers, service line issues, maybe it's specific denial reasons? It could be a bunch of different things. The second focus is true net denied dollars based on contract management. By connecting the payer remittances with the expected reimbursement, we can understand real revenue at risk on denied and underpaid claims. This helps to not only prioritize the AR in our work queues, but also helps us create monthly dollar inflows and inventory trends and allows finance to reserve appropriately. Next is standard workflow system. We needed better and more consistent workflow for all of our accounts receivable. We simply couldn't use the old legacy systems or spreadsheets to manage the AR. And the workflow itself needs to be based on the life cycle of an account, and information from the payer and the payer statusing is key to selecting the accounts onto the work list. Our take is that if an account doesn't need intervention from the CBO at this time, then we want to leave it off the work list. So we required automation from a system that could go out to payer websites and do some routine follow-up inquiries for us and drive accounts to work queues that truly needed attention, not just ones that were over a predetermined age limit. Essentially, we were always trying to prevent unnecessary touches, and we need a system that can apply workflow logic consistently across a large organization and many business offices. Next is data consolidation. With several patient accounting systems that we have and multiple billing systems and payer websites, across Prospect, there was a lot of data, but very little consistency and aggregation. We're now using tools to integrate data from multiple patient accounting systems and interface items such as follow-up notes, transaction data, and other information between the systems. That gives us the ability to consolidate reporting and compare results across markets. It also allows one view of AR and denials across all facilities and drill down data within facilities as needed. And it creates an overall visibility and greater speed of information needed for decision making. The last is consistent reporting definitions and methodology. All facilities are now working with the same denial code mappings. Everyone speaks the same language, using the same logic and definitions, and adheres to the same benchmarks. In the past, we used to have to rely on multiple systems and different calculations just to even understand a denial rate, and now we have a fully consistent approach. Also, by aggregating data into one system, the analytics team doesn't need to access every single patient accounting system on a daily basis to pull a bunch of data across the organization. They can use consolidated cuts of data instead. So as we set a strong foundation for Prospect, we've been able to focus on denials and underpayments, which are the two main sources of the cash leakage. To provide insight for all markets on denial inflow, as well as recovery performance against denied accounts, some of the metrics we look at are on this page you see here. The first is initial denial rates trended by quarter and then by month to understand how we are doing on lowering inflow of denials. So it really tracks our prevention efforts. We trend the data by quarter to smooth out any large outlier spikes, and by month so we can see quick improvements of initiatives impacting specific denials. And on the top two charts on this slide, the blue line represents inpatient denial rates and the orange is outpatient. Most of the payers did suspend some denials for a time due to COVID, largely during the April through June quarter. And as you can see, there actually was a temporary relief, and you see denial rates went down for a time. You see in the blue lines up at the top, you see them kind of go down during that quarter and then kind of come back to normal later this summer. So there was kind of a temporary relief and then a bounce back upward to almost a business as usual. In addition, one thing we're keeping our eye on and tracking is retrospective audit denials. We expect that there will be some increase in denials later in the year as payers go back and audit these cases. A bunch of the cases that were discharged back in the April to June period and have more DRG downgrades and things of that nature. So that's something we're definitely going to keep our eye on in the next few months. We also track denial recovery waterfalls. So shown in the bottom left is one example of this. This shows how we're executing on recovering our cash on denied accounts. The chart percentage shows a percentage of net dollars recovered at 180 days in blue and then at 365 in green. And we have a full report that shows it for all monthly intervals. So if we see a monthly decline, it's easy to pinpoint which month is an issue and target specific accounts to spend time on. And this is the #1 report that finance uses for denials each month, as it helps them more accurately value AR and apply additional reserves on denied accounts. One final cut we review is denials by length of stay. This analysis helps us understand our inpatient denials better, as we know that the long length of stay patients have high amounts of denied dollars at risk, but also have a larger chance of recovery due to increased documentation. And the low length of stay is a larger volume of denials that need to be worked by the clinical appeal writers. Within these data sets, we also review the reasons for denials, the downgrade to OBS, medical necessity, et cetera, and then dig deeper by facility, by payer, by service line, a bunch of different fields to determine the next steps for resolution. So with comprehensive reporting in place, as the pandemic hit, I feel we were well positioned to measure what the payers were doing in terms of not only denials, but also specific payer behavior across all the markets using one consolidated approach. The next slide shows a few examples that speak to the approach we took with COVID reimbursement analysis. Over the past 6 months, we've really been focused, and I'm sure many of the listeners have as well, on analyzing reimbursement trends for COVID positive patients and for each of our markets and validating what we're seeing and seeing if we are getting the additional payments that we expect. So back in March and April this year, very early on, we started tagging all COVID positive patients in a corporate-wide data warehouse so that we had a comprehensive list of patients and could include or exclude COVID patients depending on the analysis. So once we knew we had a handle on all the diagnosis codes and had all the patients identified, all of the additional analysis was much easier at that point. And for us, our starting point was the traditional Medicare patients. So we started billing cases back in April, and by early May, we noticed that one of our MACs, NGS, had begun paying for billed inpatient cases where we had treated COVID patients, but that our reimbursement was exactly the same as pre-COVID. So they were not adding the 20% increase to CMI. So we contacted NGS right away, and by around the mid-June timeframe, they'd reprocessed nearly all of the early billed accounts from when their system had not been set up to reimburse it at the beginning of the pandemic. So next, and you'll see a little bit of this on the slide here, a few different tables, we moved on to managed care Medicare plans for each market, and we grouped it by payer, so we were able to pinpoint any issues. So on the slide, you'll see a few tables. This is an example of how we approached the managed Medicare. At the top left, you'll see we did an overall market-by-market breakdown of all COVID-positive patients and how total payments compared to expected reimbursement. And then once each market had their overall numbers, we broke it down by payers within the market. So that's table 2 up in the top right corner. As you can see in the top right, some of the payers were paying us the additional amounts we expected, but this helped us quickly identify the payers where we needed a focus review as they were clearly not paying the additional amounts. And up in the top right corner, you'll see some of the payers were running around 115 to 120%, whereas others were still all the way down in the 90% range. The bottom table shows an example of the detailed account listings we provide to our markets so that they can see which accounts are underpaid. Here we calculate percent based on our usual rates, which enables us to determine which accounts need further review due to the lower than expected reimbursement percentage. We expect most of the accounts to show up as about 110+% based on the added COVID payments. And where we haven't been getting those increases, our rev cycle and managed care groups have been teaming up to go back to payers and give them accounts that need to be reprocessed. So by consistently reviewing our payments, our teams have been able to stay on top of the payers and make sure we aren't leaving money on the table. And it is a constant effort, though, and one that we know will be dealing with for a while. But this is what we're doing really too. This is kind of the biggest thing that we're doing right now, along with overall denials, though, is to prevent the leakage within the revenue that Jonathan was talking about. And one thing I wanted to note that was very interesting through all of this and the analysis that we've been doing is that as we've analyzed the COVID reimbursement, we actually discovered that the 20% increase to CMI weights that we've been receiving has provided less of a month-to-month cash boost than the Medicare suspension of sequestration that started on May 1st. So in other words, getting roughly 2% back from sequestration after May 1 has provided more benefit than the 20% increase on COVID-positive admissions. And that's particularly been true over the past few months as the admissions have fallen. So I will pause there and send it back to you, Morgan, for another polling question.
Great. Thank you, Ryan. Some really great detailed information there. And our next polling question is, what percentage of your net patient revenue is manifesting in denials? Is it 1 to 5%, 6 to 10, 11 to 20%, more than 20, or not quite sure? So we'll give another 10 seconds for attendees to answer that question. Thank you all for your participation. So it looks like not a lot of knowledge around this exact percentage for the majority of attendees, but those that do or are familiar with it say about 1 to 5%, and second would be that 6 to 10 range. So I'm going to pass the mic over to Cass to continue the conversation.
All righty, thank you very much for allowing me to talk to you about our daily grind and our approach to the AR. Recognizing you're only as strong as the tools and the platforms you have to use, and kind of piggybacking Jonathan's discussion of people, process, and technology, we're often out-resourced by a payer, so we We heavily rely on contract management as our predominant tool to measure, track, and combat denials and underpayments. So the contract management tool compares what the contract should have paid us to what they actually did pay us, and then identifies exceptions. We then employ as a system a consistent way of looking at the inventories and automating work queues, and we call that our enterprise playbook. The playbook itself, the process itself, will spit out variance reports that identify denials and underpayments. We do that in a methodology that's automated, so that's the center of your this puzzle up on the screen. Provides us some feedback, whether that's through the use of daily huddles and feedback from the staff, and then it allows us to replicate strategies that we use across the market. So all of that's just a fancy way to say that we leverage all of the analytics to measure our cash collected against the modeled payments. We certainly look at denials and underpayment overturn rates, the recovery rates, and then the trending and patterns. We look also at the cash collection efficiency as measured against the discharge date. So that was where we refer to waterfall measurements at 90 and 365 days. And then we look at payer efficiency. So we're still a little immature in terms of having a payer scorecard developed, but certainly as you run the variance reporting and you look at your payer exceptions, you can quickly identify those that perform better than others, those that create more administrative burden than others. And it also, the software and the technology and the tools that we have allows us to develop at least a semblance of putting together settlements to use with the payer. So sometimes it's only cents on the dollar, but it's not a zero payment for services rendered. So as an example, when we were doing a system integrity testing, we identified for one specific payer some inconsistent payment methodologies for endoscopic and GI procedures. They were either bundling procedures, paying at a percentage charge, or just paying each line item unbundled. Either way, it was inconsistent. And so we researched it against the contract and developed a payer demand letter, I'm going to say. And we provided tools to them that gave them the subscriber's ID, member ID number, claim number, et cetera. And then we showed them the calculation of expected versus actual payments. And at the first hospital, we were able to identify $450,000 in net underpayments. Once we got them to accept the methodology and that the system report was certainly supported with integrity, we then applied that same methodology. So we replicated the strategy to another Connecticut hospital. We're able to recover about a couple $100,000. And then we also brought it to Rhode Island because it was the same payer contracting folks, and we were able to identify a strategy there as well. So we were able to replicate the strategy and use it in separate markets. So similar to denial reporting, complete denial reporting, we also rely on underpayment analysis to maximize cash. So the slide here shows you two different graphs, one being inpatient underpayments, the other one being outpatient underpayments, and they're very different animals in the payer world. So typically with inpatients, if you're going to see an underpayment specific to either a per diem payer, which is usually a commercial payer because most of our payments are at a per case level, or for behavioral health where the patient was an inpatient for 10 days, but we only were paid for 8 days. So there's a slight underpayment there. The part where the system allows us some leverage is on the outpatient side because those are more discrete denials. They're smaller in dollar amount, usually larger in transaction numbers, and they're hidden often at the line item. So for example, we had a payer who was using a denial code CO45, which just means maximum fee schedule reached, I believe. And they were adjusting off the full claim. It was a small dollar, but high volume of claims. as a system error. It was just a mapping error in their system. And the way we were able to identify it was by running the variance reports that I spoke to you of. We sorted it by payer and by dollar amount. And where we saw the same dollar denial 200 times over, we were able, obviously, to identify a trend and overturn that. Also, discreetly, you can identify line item denials for infusion and injections related to LCD, so local coverage determination, or NCDs, at the line item needing a diagnosis code. Again, might be small dollars, but larger in volume. And then issues like labs, and a lot of you will see this where you have primary care services. A lab for a non-covered vitamin D. A lot of physicians order it, but they're often not covered. You wouldn't see that necessarily unless you ran a query looking for it, or unless you sorted by dollar amount to identify the same denial over and over again. This would be indicative of needing an ABN, so Advanced Beneficiary Notice Process, but needing to get to that line item and root cause would require reporting of this nature. So we use real-time view of the accounts across the facilities to allow us to be agile. And so while aging is an important criteria, we tend to look at accounts by their status, where they are in the life cycle, are they correctly paid, are they underpaid or denied. We focus, of course, first on first pass resolution, because this is first pass resolution is an indication of how quickly we can have our cash come in without any type of intervention. So as Ryan referred to, no manual intervention, no touches. You can see on the slide that the blue line itself represents denials and the red line represents underpayments. And the graph next to it is what portion of the AR is paid versus pending resolution. And then we would use data analytics to focus efforts on where to go next. So if you look back at the first pass resolution, you can see an uptick on quarters 3 and 4 in denials. So where we would go after this would be to look at those quarters by payer, by service type, and drill into the detail for those. So revenue cycle dashboards obviously provide us a way to track denials activity. And there's a lot on this slide, right? So up in the first left-hand corner, it just shows you that what portion of, in a pie chart, what portion of the denials have been resolved and what portion is outstanding. So certainly just a barometer of where we are in terms of a success rate with the payers. Beneath it is a denial trend and recovery trend by service date with percentages based on numbers and recovery rates. Where we get to the real meat of the issues is up in the upper right-hand corner, where we trend denials by major payer. We would look to see who is using deny and delay tactics to manage their cash flow. Typically that happens more towards the end of the year, in the June timeframe if you're a September year end. We would look at this by payer and then trend it by service, as Ryan kind of described earlier. So for orthopedics, for example, those are high volume procedures with typically significant dollars. So we may assign a person just looking at orthopedic denials. Specific to bone marrow transplant, those are fewer in nature. So if one of the facilities has bone marrow transplants, they're fewer in nature. However, they're higher in dollars. So affecting one denial for a bone marrow transplant could affect the AR pretty significantly. And then again, we would look at either behavioral health or infusion. So high transaction counts, where you'd have to kind of model the data, trend it, take a look at it by dollar amount, and look for the same types of categorization. I think beneath it, right in the corner, is where we think we've started to approach best practice. And Ryan alluded to this a little bit earlier. We categorize by reason and remark code off the remittances. And while the slide is small, so the verbiage on the slide is small, what it's kind of showing you is we've taken the reason and remark codes, we've mapped them to buckets that make it easier for us to be able to pinpoint what the issues are. And and then we drill down to those accordingly. So for example, the very top line of this is additional information required. It's very hard to find these denials within your patient accounting system if you haven't taken the approach that we have. And this is the #1 denial on a technical basis, and typically related to simple things like an itemized bill is requested by the payer and you need to send in an itemized bill, or they've requested a medical record and that needs to be put out on their portal, or there was a modifier required. So any one of those system issues you need to define it and then put a process to it and then hopefully automate it. So what we were able to do was drive work queues. We created work queues where an itemized bill was requested or a medical record was requested. We assigned the work queue to a specific AR rep, and each day those things fall out into their queues, and they know how to find them and address them, and then the cash comes in much quicker, and we don't have a denial related to us not providing the information timely. With this, I'm going to turn it back to Morgan for the next polling question.
Thank you, Cass, and really interesting polling question. Excited to see how attendees will respond. How has the COVID-19 pandemic impacted your relationship with payers? Has it gotten better, worse, or stayed the same? I'll give you another 10 seconds to answer that. Great. Thank you all again for your participation. Looks about, more than half are saying it's about the same, and there is about 30% of attendees who said it has gotten worse. So really enlightening there. I'm going to pass it back to you, Cass.
Okay, thank you. In terms of it getting worse, we have seen specifically at our facilities that the lag time to get responses to claims issues or underpayments or even lagging payments has really, it's really been decreased. So I'm not surprised by the answers. In our journey, in terms of our journey to best practice, I think using one version of the inventory allows for certainly consistent workflows, right? Everybody employs the same approach for resolution. The staff knows what they need to do when they get in, or when they at least access their work queues remotely. They're not waiting on direction. They know where to go, what to do. They know the policies and procedures on how and where to escalate issues to and to whom to escalate them to. And it allows us to kind of refine the work queues and adapt and react pretty quickly. Using daily cash huddles, again, we do cash huddles and then we do high dollar claim huddles. And then finally, it fosters communication, which is then funneled to the finance team. So it allows them to either tweak AR valuation or at least make some accruals for things that they may or may not have known about, which is really the true definition of revenue cycle, right from front to back, all the way through to the financial statement preparation. Again, the best in our journey to best practice, and where I think we've differentiated ourselves maybe from others, is in the roll-up categories that accelerate department denial review. Ryan spoke of them, and then I spoke of them earlier, right? It does take a village to be able to keep up with the payers, and so issues are easier. Some issues are easier to track than others, like COB and eligibility. When that's categorized and the numbers are all put together, you have the ability to try to look at it by service area and understand if the staff is ignoring the alerts or the tools they have available to them. Are they understaffed? Is it possible that there's no process to cover when there's a patient surge in the ED, for example? They're heads down trying to register patients, so they don't have time to work the insurance edits that are telling them they have the wrong payer or plan code. You need to have someone come in behind them and kind of clean up their mess, whether that's a supervisor or a manager, particularly during the COVID crisis when they were just trying to get folks in the door. Or does the bucketing of claims start to identify that there are harder issues that need to be resolved with IT? maybe systemic in nature related to the EMR, whether that's Cerner, Epic, Meditech, et cetera. Certainly using a rich data set allows you to define root cause, chunk out the script to figure out how to resolve and recover. I think with that, I'm going to turn it back to Ryan for his final thoughts, and then we'll have a short question and answer period.
Thanks, Cass. So just some final thoughts here. Consistency is key. You need everyone speaking the same language, using the same logic and definitions, and applying the same benchmarks and metrics. Collaboration is critical from system and human perspective. So consolidation of information from multiple sources that we talked about, that's helped us create greater insights and also create more sharing of knowledge and collaboration between user groups such as our CBOs and clinical teams and managed care. Trending analysis, the ability of a system to timestamp events like the first denial and first underpayment are critical. So they allow a starting point that gives you the snapshot in time, but then also allows to provide a starting point for a longitudinal study of where the claims are in the life cycle and the ultimate resolution of the account. We need to understand full denials and line item denials and be able to understand the CPT level detail on outpatient claim denials. You need drill down capabilities. So the trended reports are nice, but all of the stuff we showed you some of these things, Cass and I did, but all of these are now accompanied as well by organized data sets to provide enough field detail to do drill down so we can spot trends by the service lines, the service locations, payer, reason, et cetera. And last is work queues and saved searches. I think most of the listeners are using some sort of work queues to organize work efforts and create a good ownership structure for the accounts receivable. Another piece that we're using is saved searches, and it's an inventory management technique where we use saved searches that are queries that we know that will be repeated and replicated over and over. So we create a useful template. So for example, if a manager wants to review their top 50 open accounts in accounts receivable each week, it's a simple click of a button and returns the accounts to review. So this, along with the queue structure, will help you manage inventories more effectively. So I'll stop there. Any other thoughts from the group until we open up for questions?
I don't have any. I think it'd be good to see what the crowd has for us.
All right, sounds good. I will jump in, and thank you, John, Ryan, and Cass, for a fantastic presentation. And as I said, we'll now begin today's question and answer session. So just a reminder, please submit any questions you have by typing them into the Q&A box you see on your dashboard. And there's already quite a few questions that have come in, so really looking forward to diving into those. So start off with the question, might be best for Ryan or Cass, but the audience member is wondering, what automation tools do you use for denials in AR management?
So right now we are kind of a combination. We use Allscripts for our case management and clinical denials, and we also use Rubixis, which is a TransUnion product, for kind of an overview and kind of an all-encompassing product for denials.
Great, thank you so much for a great question, and that answer was excellent as well. I'm going to move on to a question about denial rates, and I think, Ryan, this might be about your section of the webinar, but an audience member is wondering, is the denial rate calculated using the HFMA definition, or is it something else?
So we use a definition where we do it by, essentially by accounts. So let's just say we had 100, just to make it very simple, if you had 100 inpatient accounts in 1 month, inpatient discharges, and 10 of them end up getting denied, then it's a 10% denial rate. So just for the simplistic purposes, that's basically the way we do it. It's kind of based on an encounter level, and then we don't double count. So it's possible, obviously, I know everyone's dealt with multiple denials on accounts. We make sure that it's only included one time, because at the end of the day, if those 10 out of the 100 are worth, say, $10,000, it's really $10,000 at risk. You can't kind of keep adding that revenue at risk, because it's really each claim can only be the expected amount that we want to pay by the payer that's at risk when we get that denial.
Okay, thanks for breaking that down. It's really helpful to, lay that out a little bit more. The next question is about CARCSs. And so, they're wondering what CARCSs do you include in your denials reporting?
Ryan, I'm going to let you take that one because you know the CARC codes better than I do, I think.
Yeah, and actually that they cut out for a second. It was what AR do we include? I didn't catch it.
I think it's
okay.
what CARC. Yep. What CARC codes do we include for denials reporting?
Oh, gotcha. Okay. Thanks, guys. So we include really, any CARC code that comes across on the account can get included. What we actually do though is we take a different starting point for denial. So we didn't talk about this earlier. This is a good question. We don't use the CARC codes themselves as the starting point for a denial. We don't look at the CARC codes in general and say, hey, I see that CARC code, now I know it's denied, because a lot of times we did kind of touch on this, the line item denials that will come through, but it's on a paid correctly claim, right? We billed it out, we expected $1,000, we got $1,000 back. There could still be a line item denial, and we don't really want to include that. So our starting point is really, hey, we build this out, and then if we get a zero pay back, that's our, hey, we got a denial on this, right? So that counts as a denial, and then the ones we get a partial pay on really kind of go into like an underpaid status. And then for the CARC codes, though, we do take all of the CARC codes and we roll them up. I think Cass talked about this before. One of the things that you see in one of the what she showed was you might have a bunch of 6 different reason codes that mean coordination of benefits. We roll those all up into one, so it's a lot easier to find all those. And then we break down into informational, the clinical and technical denial. So we get into kind of those root cause reasons and kind of a denial type within those as well.
Great. Thanks, Ryan, for clarifying that. The next question is about inpatient denials. Someone is wondering, what process do you use to achieve such high overturn rates of inpatient denials? Really great question. So I'll pass that on to Cass or Ryan or whoever feels like jumping in.
It is a really great question. We've spent a lot of time on getting the right status the first time. So we've done a lot of education on starting patients as an outpatient, escalating to observation, and then, converting that patient into inpatient when appropriate. Can I ask someone to go on mute, please? There's a lot of banging in the background. We also spend a fair amount of time watching the symptom-related admissions. So admissions that are related to chest pain and abdominal pain, or outpatient procedure-related ones like appendicitis and lap choles. Those are outpatient each time. So we've done a fair amount of education on those. In terms of being able to have a good overturn rate, we have spent a fair amount of time on bulletproofing our case management process. So making sure that the clinicals we provide the first time are appropriate and applicable. So we don't send information that's not needed. We try to make it appropriate for the reviewer. And certainly if you get to the point of needing a peer-to-peer, or we have to do a first and second level appeal, we make sure each one of those steps has additional information worded differently or more specifically. There are times where if our case managers know the reviewer, they will call and ask, what portion of the record are you thinking is missing from here? What is it that you need? Do you have the history and physical? Did you want the easy admission and just the first day clinical, or is it more effective if we give you admission and the first 2 days with a plan of care? And then we've had some pretty significant work done on readmission. So we have nurse appeal writers. So they are clinical RNs. In the East and on the West Coast, we use more of a foreign medical graduate model. These are the folks that write the appeals and provide the clinical documentation, and then will kind of refute the payer's viewpoints on the denial. So we get a fair amount of denials related to readmissions, and we're able to overturn those as well, showing that the first initial index admission was a complete form of care, and that sometimes a readmission is just progression of the disease and may be unrelated. I'm going to pause there. I think I gave you a lot.
No, it's really helpful, and that peer-to-peer advice is really, something that people appreciate. So thank you so much, Cass. Have another question, and just a reminder, keep submitting questions. We have so many great ones coming in from the audience. And the next one is, do you collect money after technical rejections, whether they be a medical records request or something else? So do you count money collected after that as recovered denied cash?
We do. I mean, essentially,
Right.
anytime we have a full denial that comes across, we expected $1,000 and we initially got $0. Really, no matter when we get that in the life cycle, eventually if we end up with $900 on that account, and then it ages out, and we end up with 900 out of 1,000, that account would just get counted as 90%. So we don't really do here's exactly when this happened and then how much we got. We just look at what in totality did we expect, and how much of that did we end up getting.
Got it. Thanks for clarifying that, Ryan. Next question is about out-of-network denials. The audience member is wondering, do you have any specific advice or suggested resources to address out-of-network denials?
So out-of-network denials are typically, go ahead, Ryan, go ahead.
No, I was going to say, go ahead and take that one, Cass.
Oh, okay. Out-of-network denials, obviously, if emergent, those are easier to address simply because of EMTALA rules and payer expectation for emergency care. We do have 2 attorneys on staff who will write appeal letters for us. Oftentimes with an out-of-network claim, you're typically in the position where you have to justify why it is the patient couldn't go somewhere else. And so we try to wrap we do it through an appeal, and we try to wrap all the clinical reasons together why it is the patient needed to have care that day, in that setting, in that circumstance, in one of our hospital facilities. Aside from that, though, if it's not an urgent care and it's particular to, the patient having been responsible, we would then, when all else fails, you turn it over to patient responsibility, because they are required to know certainly their network and where is in and out of network. I'm not certain if I answered that question entirely. I'm assuming that you're talking about denials that came from an urgent or emergent setting.
Yeah, I think that's exactly it, Cass. Thank you for diving into that further. We do have time for one more question today, and that is, what role has the technology you mentioned had in mitigating your underpayments and denials?
Brian, you want to take that?
Yeah, I mean, I think that I was talking more, earlier about kind of our denial capture and a lot of what we were doing to consolidate data. And then we have used the Revixis tool from TransUnion a lot to kind of identify all the denials on the back ends that are occurring, and making sure that we're recovering all of our dollars, because it also connects in with the contract management as we spoke about, so we know that true revenue at risk and how much we're recovering.
I think just to piggyback on that answer too, following up with people, process, and technology, when you have the tools in the front, it doesn't mean that everybody uses them. So I think the other piece is a supervisor and management monitoring perspective, which means the folks responsible for being leaders need to go in and make sure that the folks are using the tools available to them. They have cleaned up the edits that have been identified, or even in the back where we have a variance or some type of exception in payment, are the managers and supervisors following up and monitoring that the staff is doing the appropriate follow-up when opportunities are identified. So there is a little bit of onus on us as leaders to make sure that all the tools are used to the maximum capacity.
That's great. Thank you both. It's been an awesome Q&A session with a lot of great dialogue and insight across the board. So thank you to the audience for participating as well. Before we close today, John, Ryan, Cass, do you have any final thoughts to share?
I had, I wrote down an ounce of prevention is worth a pound of cure. So our best actions are not reactions. It's preventative and proactive, prevention. So thanks.
Thanks for letting us share.
Yeah, absolutely. A great theme to end on. And just a final thank you to TransUnion as well for sponsoring today's webinar. To our audience, please enjoy the rest of your day, and we truly look forward to having you join us for future webinars.